Welcome to the VetEmCRIT Academy, where we discuss veterinary emergency and critical care and science-based tools for vet professionals. Today, I'll be walking you through a real-life case involving a hypernatremic canine patient with signs of hypovolemic shock. And I'm going to demonstrate how you can use our completely free online custom sodium solution and free water deficit calculators to create a tailored treatment plan for this patient. These tools can save you a lot of time and mental energy during your busy hour shifts. You can find both calculators at VetEmCRIT.com. Just go to the homepage, scroll down, and click on Custom Sodium Solution Calculator or Free Water Deficit Calculator. All right, let's meet our patient. Maggie is a 6-year-old female spayed Labrador Retriever weighing 28 kilograms. She presents with a history of severe, intractable vomiting and mild diarrhea after spending a few days at a boarding facility. Her vomiting is so severe that she would vomit every time she drinks water. On examination, she has a heart rate of 150 beats per minute. Her femoral pulses are fair to weak. Her mucous membranes are pale pink, and she has dull mentation and moderate dehydration. The combination of this history and physical examination findings are consistent with possible hypovolemic shock. However, other types of shock can't be ruled out without further diagnostics such as point-of-care ultrasound and blood work. The point-of-care blood work shows hypernatremia, high sodium in the blood, with a sodium concentration of 179 milligrams per liter. She also has hyperchloremia, high chloride, normal blood glucose, normal plasma potassium, mild azotemia, and hema concentration. In addition, Maggie's point-of-care ultrasound confirms our suspicion of hypovolemic shock. By the way, you can download a free diagnosis of shock checklist by clicking the link in the description. So we strongly suspect that Maggie has so-called hypovolemic hypernatremia caused by severe gastrointestinal signs leading to loss of hypotonic fluids. But not all patients with severe GI signs develop hypernatremia. So why did it occur in Maggie? The body has two key mechanisms to correct hypernatremia: increase water consumption and increase water reabsorption in the kidneys. These mechanisms help maintain normal sodium concentrations. In Maggie's case, her intractable vomiting prevents her from keeping water down. This means her natural compensatory mechanism, drinking water to dilute the sodium down, was ineffective, leading to elevated plasma sodium levels. Now that we understand why Maggie developed hypernatremia, let's talk about our next key management steps. First, we need to correct her volemic shock by administering a fluid bolus. However, it's important to be cautious. Rapid correction of hypernatremia can lead to serious complications, such as cerebral edema or brain swelling. So our goal is to gradually decrease her sodium concentration while addressing her hypovolemia. To prevent rapid changes in sodium levels while giving a fluid bolus, we need to choose a crystalloid solution that matches Maggie's plasma sodium concentration. In this case, her sodium is 179 milligrams per liter, so we want to create a custom crystalloid solution with a sodium concentration closer to 179 milligrams per liter. Since no commercially available solutions match this exactly, we're going to quickly make one using the custom sodium solution calculator on VetEmCRIT.com. Let's head over to the custom sodium solution calculator. This tool will help us calculate how much hypertonic sodium chloride to add to our baseline solution to create a custom solution with a sodium concentration of about 170 milligrams per liter. We start by entering first the desired sodium concentration in the final solution, which is about 170 milligrams per liter. Next, we'll enter the sodium concentration of our baseline solution. This could be any crystalloid solution with sodium concentration less than patient's plasma sodium concentration. In this specific case, we're using normal saline or 0.9% NaCl, which contains 154 milligrams per liter of sodium, which is less than in a patient. Then we'll enter the sodium concentration of hypertonic saline, which is 7.2% solution, and it has 1,232 milligrams per liter. The sodium levels of common commercially available solutions are conveniently listed in Table 1, located just below the calculator, so that you don't need to go anywhere else to find this information. Finally, we'll input the total volume of the solution we're making, which is 1 liter or 1,000 mils. After clicking Calculate, we receive our result. We need to add 14.8 mils of hypertonic saline to 985.2 mils of normal saline to make a custom solution with a sodium concentration of 170 milligrams per liter, which is exactly what we need. This custom solution is safe to bolus to Maggie to correct her hypovolemic shock without risking cerebral edema. Once Maggie's hypovolemic shock is corrected, our next focus will be on lowering her sodium levels gradually over the next few days. To do this, we need to calculate her free water deficit, the amount of water required to correct her hypernatremia safely. Now, we'll head over to the free water deficit calculator. We enter Maggie's plasma sodium concentration of 179 milligrams per liter. Next, we enter our target sodium concentration, which is usually the upper range of normal, and it will be around 153 milliequivalents per liter. Finally, we enter Maggie's body weight, 28 kilograms. After clicking Calculate, we see the result. Maggie's total free water deficit is 2,855 mils. Since we don't know exactly when Maggie developed hypernatremia, we need to correct it slowly. The goal is to reduce her sodium by about 10 to 12 millimoles per liter per day, or 0.5 millimoles per liter per hour. This means it will take approximately 52 hours to correct her hypernatremia safely without causing cerebral edema. To achieve this, we will start Maggie on a sodium-free fluid, such as dextrose 5%, at a rate of 55 ml per hour. We will monitor her sodium concentration every 4 to 6 hours to ensure we're on the right track, especially during the first 24-48 hours. Throughout the treatment, it's important to closely monitor Maggie's sodium levels, neurological status, perfusion parameters, and urine output. All these parameters will help us determine how well the therapy is working and whether any adjustments are needed. As you can see, the custom sodium solution and free water deficit calculators are valuable tools to help you safely and effectively manage hypernatremia in your patients during busy ER shifts. Remember, not all patients with hypernatremia require the same fluid therapy. Even more, they may not need fluids at all. There are many nuances in managing this condition. If you found this video helpful, check out more educational content on our YouTube channel, VetEmCRIT. And thanks for watching. See you in the next video.